everybody for our last talk today, which is on update on fertility management for girls and women with Turner syndrome. So here is an outline of my talk. I'll just talk briefly on a bit on diagnosis and genetics, and then I'll focus more on puberty, hormone replacement, preconception counseling, and fertility and reproduction. So Turner syndrome is actually not a very rare condition. It is a genetic condition that affects 1 in 2,500 of female live birth, and it requires a multidisciplinary team management with geneticists, endocrinologists, cardiologists, gynecologists, and also psychologists. Going on to a brief overview on the genetic. So basically for girls and women with Turner syndrome, they have one intact X chromosome and another complete or partial absence of the second sex chromosome in association with one or more clinical manifestation. The most common karyotype in Turners will be 45X, around 40 to 50% of them. And then we also have the second most common, which is mosaic Turners with 45X and 46X karyotype. And sometimes with different karyotype, the girls and women can have different phenotypes or presentation as well. But for this presentation, I won't go into the detail on the different phenotypes or presentation of the different karyotypes. So next, I'll talk a bit about on puberty and on hormone replacement therapy. As a lot of the girls with Turner syndrome, they can have issues with premature ovarian failure, which is one of the endocrinology problems which is encountered by a lot of the girls and women with Turner syndrome. So for puberty induction, the aim of puberty induction is hoping to mimic a normal physical and social development. Because for girls with premature ovarian insufficiency, they are often unable to have spontaneous puberty. So often they might require estrogen replacement. So if, especially for those with 45X karyotype, if they already have premature ovarian insufficiency before the age of puberty, we can start estrogen replacement around 11 to 12 years old, trying to mimic a normal spontaneous pubertal development and increasing to an adult dose over 2 to 3 years, with an incremental dose increase every 6 months to mimic a normal pubertal tempo, with around 25 to 100% increase in every 6 months. But it is important to start with a low dose of estrogen, as a very low dose estrogen does not interfere with growth response to growth hormone therapy, which is often used in girls with Turner syndrome. And so that is the aim of the puberty induction. And over time, with the development of the pubertal development and also with the development of the uterus, the girl may start to have some breakthrough bleeding. So once there is breakthrough bleeding, or at around approximately 2 years of initiating estrogen, we can do an assessment of the size of the uterus with an ultrasound, or when there is breakthrough bleeding, then we can consider adding in progesterone. Sometimes, and it's also important to note that we should assess the development of the uterus and the breast at the same time, so that progesterone sometimes may be deferred to allow more time for breast and uterine development. And some other points to note is that if the potential for taller stature is still possible, then girls can consider remaining on a lower dose of estrogen a bit longer. And the older in initiation, the duration of time until adult dosing may be shortened. For example, in those girls who have a delayed diagnosis of Turner's at, say, 18 or 19 years old, then the duration of time until adult dosing may sometimes be shortened. And on average, the onset of breast buds usually occur around 6 months after initiation of estrogen. And to reach a Turner stage 4 breast usually takes around 2 years' time, which is similar to puberty in 46XX girls. So here is a table showing the recommended dosing from an international guideline consensus on management of Turner syndrome. So here is the suggested dosing, which you can consider following with transdermal dose, oral dose, and the years for puberty induction, and how we monitor the estrogen levels during the puberty induction process. So going on to hormone replacement therapy, once the girl has undergone puberty induction, they often require lifelong hormone replacement therapy because of premature ovarian insufficiency. So the first question that we need to ask is which route is best for HRT or for estrogen, because for hormone replacement therapy, there are two parts, the estrogen and progesterone. So there are some recommendations, but these are based on theoretical and available studies, mostly on postmenopausal women, and there is no study specifically on Turner syndrome girls. As estradiol is normally secreted into the systemic circulation, so the liver receives the same concentration as other somatic tissues. Therefore, a systemic route of replacement is usually more physiological, and delivery of estradiol by transdermal, transvaginal, or parenteral administration more closely mimics the physiology. And also, studies in postmenopausal women shows that with the oral route of estrogen replacement, it is associated with a procoagulable state and increased risk of stroke. Thus, if possible, a transdermal route might be more recommended to replace estrogen. Then the second question is, because there are multiple types of estrogen, which type of estrogen is the best to be used as HRT? So there is ethinyl estradiol, conjugated estrogen, and also estradiol in the form of estradiol valerate or estradiol hemihydrate. So for these different types of estrogen, for ethinyl estradiol, it is most commonly found in combined oral contraceptive pills. So historically, this has also been used as an HRT in women with premature ovarian insufficiency, including those with Turner syndrome. It is a long-acting estrogen, therefore it cannot mimic the typical diurnal variations seen in early puberty. And also, serum concentration of estradiol cannot be measured meaningfully for those while on ethinyl estradiol. It also has an adverse cardiovascular and metabolic profile, and especially for women with Turner syndrome, tends to increase blood pressure and is linked with an increased risk of venous thromboembolism, which is of a concern in these girls and women. Whereas for conjugated estrogen, it is developed from the urine of pregnant horses. However, compared to estradiol, it is associated with an increased risk of thromboembolism, so it is not recommended. So the most physiological option will be estradiol. So when there are studies looking at different types of estrogen, but these are data mostly from postmenopausal women. When comparing estradiol, ethinyl estradiol, ethinyl estradiol was significantly associated with an increased risk of thromboembolism and also an increased risk of myocardial infarction. And estradiol has a superior effect on bone mineral density compared to ethinyl estradiol. So this study, they looked at women on transdermal estradiol versus those on oral ethinyl estradiol, which is the cyclical oral contraceptive pill. And they found that the bone mineral density at the end for those using transdermal estradiol seems to be better compared to those on oral ethinyl estradiol. But one point to note for this study is that those taking the oral contraceptive pills, they're taking it in a cyclical manner, meaning there's a pill-free week. Versus those who are on transdermal estradiol, they're receiving their estrogen continuously, along with 2 weeks of vaginal progesterone. So this one is another study. It's a 2-year open randomized trial comparing hormone replacement therapy, which is the traditional HRT with estradiol with or combined oral contraceptive pills. And they looked at 50 women with premature ovarian insufficiency. And they looked at the HRT regime versus oral contraceptive pills regime, which is a cyclical method. and there is significant difference in the bone mineral density for those that are taking OC pills, which is of a lower bone mineral density compared to the traditional HRT. So the next question comes to which type of progesterone is the best. So progesterone mainly is prescribed as part of the HRT for endometrial protection. Normally, like natural progesterone has a poor oral bioavailability, but this can be improved by microionizing. When we look at data from the postmenopausal group, this dose seems to be devoid of adverse effects on blood pressure, lipid profile, breast cancer risk, and thrombotic risk for those on microionized progesterone. And another option is medroxyprogesterone acetate. It has also been widely used in HRT because of its bioavailability orally. It's over 90% and it has a high potency. And its half-life is 24 hours, allowing for daily dosing. It is also effective at providing endometrial protection. However, it primarily acts on the progesterone receptor. It also acts on the glucocorticoid receptor, giving rise to potential glucocorticoid-like adverse effects, including an increased risk of breast cancer in non-Turner syndrome populations and stroke in postmenopausal women. Another option is norepinephrine, but this is a testosterone derivative, and there can be mild androgenic effects. But having said that, there have been no studies just focusing on Turner syndrome patients, comparing the different progesterone options. So what about those that require contraception? Theoretically, even those that have premature ovarian insufficiency, there is still a possibility of pregnancy with around 5% per year. So if the woman is not planning for pregnancy and they require hormone replacement therapy along with contraception, these are the options that we can consider. So first option will be a levonorgestrone releasing intrauterine device along with a method of estrogen replacement, which can be oral or transdermal. Of course, if the woman is having the transdermal estrogen along with the levonorgestrone releasing intrauterine device, this is they can have a lower risk of thromboembolism compared to like an oral option of estrogen. And also the LNG-IUS is actually licensed for use as progesterone part of the HRT and also as a contraception. And another option is the pill called Clara. For Clara, this combined oral contraceptive pill, they have estradiol valerate as the estrogen component for the oral contraceptive, along with Dianogest. So it is a tricyclic pill with different components of estrogen and progesterone in different times of the cycle for the pill. It is also the only oral contraceptive pill licensed to be used as an HRT. But because of the different components or composition of the pill during different parts of the cycle, it is very important to have a very good compliance. And missed pill can have a higher chance of having an unwanted pregnancy. So going on to fertility for women with Turner, it is very important to have a good preconception counseling. Because despite a reduced fertility potential, Turner's women still have a chance of getting pregnant spontaneously. There are also concerns and risks in pregnancy for Turner syndrome, which is increased compared to the normal population. Therefore, counseling is particularly important for this group. For these women, they have a higher chance of miscarriages and also double the risk of having preeclampsia, with up to 1 in 5 chance of having preeclampsia, no matter they're getting pregnant naturally or using donor eggs. And also because of their short stature, they are at risk of developing, of having capillopelvic disproportion, meaning a higher chance of requiring a cesarean section. Another thing that is of particular importance is cardiovascular health issues, because cardiovascular issues can be a major cause of mortality and morbidity in women with Turner syndrome. In particular, some of the problems which we might encounter for Turner women and girls and women, including a bicuspid aortic valve, coarctation of aorta, cerebral vascular disease, aortic dissection, and also hypertension and ischemic heart disease. Aortic dissection is of a particular importance in girls and women with Turner. So their incidence is around 40 per 100,000 person years. And also the aortic dissection appears to occur at a smaller diameter compared than those with other genetically triggered aortopathies. And also the median age of aortic dissection is young, at around 20 to 25 years old, with a range of 4 to 64 years old, which is similar to other genetically triggered aortopathies. And also, most aortic dissections originate in the ascending aorta, which is a type A dissection, while a smaller percentage has originated in the descending thoracic aorta. And aortic dilatation and enlargement of the brachiocephalic and carotid arteries can be present even in the absence of structural heart disease. So in the guidance, there is some suggested recommendation on the dilatation index for monitoring for these girls, because many individuals with Turner syndrome, they are significantly smaller in age and sex match controls in general population when they are getting the aortic dilatation. And also their size, their general body size is smaller as well. So that's why they recommend using the aortic size index, which divides the aortic diameter with this body surface area. And they have a recommendation of Keith Turner syndrome specific set score of over 3 is considered important. And there is actually a management guidance in the guideline, which I have mentioned. And in particular, for those who are planning to get pregnant and those with Turner syndrome, an imaging of the thoracic aorta and heart with a transthoracic echocardiography and a CT or MRI within 2 years before planning of pregnancy or artificial reproductive technology in all women with Turner syndrome is recommended. And actually, those with an ascending aortic size index of more than 2.5 centimeter per meter square, or those who are at a range of 2 to 2.5, along with some other congenital heart or aortic conditions, are recommended to have contraception and not to get pregnant because of the risk of aortic dissection, which can be a cause of mortality. And here, the Turner Syndrome Support Society from UK actually produces a card which can be carried by girls and women with Turner syndrome in their wallet. So in case they really collapse on the street, then the paramedics will know that they have Turner syndrome and they are at risk of dilatation of aorta and also aortic dissection. And this can be form part of the differential diagnosis in case there is sudden collapse on the street and the woman is sent to the A&E. So the risk of hypertension is pretty strong in this group, as high as 20 to 30% in childhood and as many as 60% of adults. Thus, it is very important to have good control of hypertension of the blood pressure before the woman embarks on the pregnancy. So what about fertility and reproduction? Because Turner syndrome girls, they are born with significantly less primordial follicles compared to a normal infant who has around 2 million primordial follicles when they're born. They are at a higher risk of being infertile. And even for those with mosaicism, they have a bit more follicles, but compared to the normal population, it might be decreased. But indeed, for those with mosaicism, it seems to be better compared to those with the full 45X karyotype. So one of the options that we can consider is using anti-Mullerian hormone, which is a new, a marker developed in the recent years for looking at the ovarian reserve, because the AMH is produced by granulosa cells of early stage follicles, and thus it can reflect the ovarian reserve. And AMH in Turner syndrome can correlate with follicular presence and aiding in fertility assessment, in particular for those with a mosaic karyotype, when we are thinking about when to consider fertility treatment for them. So for 45X karyotype, individuals who have a very low or undetectable AMH may indicate they have a very low or minimal ovarian function. So for those with the mosaic Turner syndrome karyotype, if they have higher AMH levels, it means they still have some preserved ovarian reserve. And the clinical use of AMH in prepubertal girls and elevated AMH levels predict residual ovarian function, guiding early fertility preservation decisions. And while in adults, the low AMH levels can correlate with the reduced oocyte availability, and this aids in the counseling in whether oocyte donation might be necessary. And sometimes the AMH can help identify candidates for fertility preservation as well, whether it is oocyte or ovarian tissue cryopreservation. But a point to note is that AMH can also be low in prepubertal inactive ovaries. Thus, there are guidance recommending a serial measurement of AMH, which can give us a better idea on the optimal time to consider fertility preservation strategies. So going on to fertility options for Turner syndrome. So first of all, of course, there is option of donor oocytes by utilizing donor eggs from healthy women. This can allow women with Turner syndrome to achieve a pregnancy, and where the donor egg is fertilized with their partner's sperm, and the resulting embryo is transferred back to the women's own uterus. And there is the other option of oocyte cryopreservation for those who does not have a partner yet. And some women, if they have residual ovarian function, they can undergo oocyte cryopreservation, also known as egg freezing. And then the harvested and frozen egg can be thawed later on when they have a partner and wants to have a family, and used for IVF at a later time. And ovarian tissue cryopreservation, it can be an option for girls and women who have not yet reached puberty, and where a portion of the ovarian tissue is surgically harvested and cryopreserved and later transplanted back to the women to potentially restore the ovarian function. And last but not least, adoption is of course an option for those who are unable to achieve a pregnancy, who are not fit, or those who are not fit to get pregnant. So when we're looking at donor oocytes, so this is a systematic review which looked at the live birth rate in Turner's women using donor eggs. So we can see that the live birth rate per patient using donor eggs is actually pretty good, around 40%. And most patients tend to have, for those mosaic patients, they tend to have less systemic involvement, also with better cardiovascular profiles, which may reduce pregnancy risk. But when we look at the table here, outcome for mosaic Turners and also full Turner syndrome, we can see that the live birth rate is actually better for those with mosaic Turner syndrome. But another point of focus is the risk of hypertensive disorders per clinical pregnancy is around 12%. It's still quite high, despite using donor oocytes. So for hypertensive disorders which can be encountered during pregnancy include gestational hypertension, mild or severe preeclampsia or eclampsia. And it was quoted to be around 12%, but for the studies, they note that the hypertensive disorders often manifest after 20 weeks of gestation, whereas a lot of the studies with the outcomes only reported up to 6 to 8 weeks of pregnancy. Thus, the true incidence may be actually higher in later gestation. And also, high cardiovascular risk profile in Turner syndrome women actually warrants intensive preconception cardiovascular screening, which I have mentioned before. So the other option we are looking at is oocyte cryopreservation. So this study, they looked at a 14 Turner syndrome women undergoing egg freezing. All of them totally underwent 24 cycles. But because of the small number of patients, they further identified by a systematic review another 48 patients in publications, a total number of 71 cycles. The mean age of those undergoing egg freezing is around 21 years old. When they looked at the data, total of 14 patients and 24 cycles, plus those identified in the systematic review, the mean number of mature cryopreserved oocytes per cycle is around 4. And there are actually very few patients able to get clinically useful number of oocytes in one cycle alone, which is quoted to be around 15 oocytes in order to achieve one live birth for egg freezing. Thus, multiple stimulation cycles might be required, and it is also accepted by the patients. And so the mean number of cycles required per patient is around 2.4 cycles, which allows them to have an improved yield, with over 50% able to get over 10 oocytes and around 43% of them able to get over 15 oocytes. And without accumulation, meaning without performing multiple cycles of stimulation, only 1 out of 7 patients exceeded 10 mature oocytes. So here are some of the predictive markers on whether they were able to get oocytes. So first of all is the basal FSH, if it's less than 5.9, and AMH more than 1.13 nanogram per mil. So this is to be expected because these are both markers of ovarian reserve. So meaning with the better ovarian reserve, of course, you are going to be able to get more eggs. And another is karyotype, is if the girl has a mosaic Turner karyotype with 46 XX cells, this is also a good predictor of able to freeze some eggs. And here, when we look at the correlation between FSH, AMH, you can see that the lower the FSH level, the higher the number of cryopreserved mature oocytes, and the higher the AMH, the higher the number of cryopreserved oocytes, and also the higher the percentage of 46XX karyotype, better the chance of getting a higher number of mature oocytes. So when we're counseling the patient for egg freezing, we need to tell them that they most likely will require repeated cycles of ovarian stimulation in order to obtain adequate number of eggs. And also, there can be heterogeneity between cycles because there is a possibility of mosaicism in the affecting follicular karyotypes as well. And even young patients might require more oocytes because of the higher aneuploidy rates because of the karyotype. And so far from the studies, we do not have an ideal number of oocytes required for one live birth in Turner syndrome. But for general population, it is recommended to be over 15 in order to achieve one live birth. So it remains challenging for this group. And for younger girls, currently there is not enough evidence to recommend routine fertility preservation for those before the age of 12 years old with egg freezing. And so far from the literature, there has only been one reported live birth so far after ovarian stimulation in those undergoing egg freezing. And There is one study with Turner syndrome biopsied ovaries, which showed that a high proportion of the follicles were actually morphologically abnormal, which highlights the concern of the risk of miscarriage and chromosomal abnormalities in the offspring in this group of patients. So how about ovarian tissue cryopreservation? So for ovarian tissue cryopreservation, it is this technology is established already for women undergoing gonadotoxic therapy, chemotherapy, but it is still experimental in the Turner syndrome group due to the underlying ovarian dysgenesis. And there have been studies going on looking at the biopsying the ovaries of women and girls with Turner syndrome. And in this study, they have found like 26 to 32% of Turner syndrome patients actually, they were able to identify follicles after an ovarian biopsy or ovarectomy for various reasons. And 60% of the patients actually were found to have follicles in their ovarian tissue. And the karyotype seems to be of great influence for those with the mosaic Turner karyotype. They have the highest follicle presence. And whereas for those with the full Turner karyotype with 45 eggs, they have the least number of follicles in their ovarian tissue. So here are some positive predictors for follicle presence in the ovarian tissue. So for those who were able to have spontaneous stellarchy, spontaneous menarche, and also FSH of lower than 10, they have a higher chance of finding follicles in their ovarian tissue. But having said that, there's challenges for those when we're considering ovarian tissue cryopreservation in this group. Because the follicle density in the ovarian tissue is significantly lower than in age-matched controls. And a high percentage of the follicles actually show abnormal morphology, which can have an impact on fertility potential. So another concern is that there can be follicular loss after transplantation due to ischemia in transplanted tissue, which further affects the number of follicles in the ovarian tissue. And also, the limited ovarian reserve at the baseline can raise concerns about the feasibility of pregnancy. So the current clinical stand is that ovarian tissue cryopreservation is still experimental, and in this group of patients, and should not be offered routinely as a clinical practice, and not only under research and with ethical approval. And the best candidates to consider ovarian tissue cryopreservation are those with mosaic Turner syndrome, with spontaneous puberty, with a low FSH and a good AMH. But counseling is essential to avoid unrealistic expectations regarding pregnancy success because of the lack of data in this group. So going on to the future, there is actually a first case of ovarian tissue allotransplantation in a Turner syndrome patient reported in the literature in 2025. So for this case, it was a 20-year-old woman with 45X Turner syndrome who wants to have a natural conception without using donor egg, IVF, or hormone replacement therapy because of religious issues. And her donor is actually her 22-year-old non-identical sister with a normal karyotype with HLA compatibility, but ABO incompatibility. And ovarian tissue was harvested and transplanted orthotopically, meaning harvesting the tissue and then transplanting back into the patient's own body in the pelvic cavity. And then afterwards, they used a immunosuppression protocol similar to kidney transplants. And a 5-month post-op, the Turner patient actually resumed having normal menstrual cycle and improved ovarian function without using any hormone replacement therapy. So this graph illustrates the change in the FSH levels and also the AMH level for the women after allotransplantation of ovarian tissue. So the drop in the FSH levels indicating an improving ovarian function after the transplantation, and subsequently the woman actually got pregnant naturally. So here are the take-home message for my talk today. So women with Mosaic-Turner syndrome should be managed as those with Turner syndrome with counseling and surveillance. The importance of preconception counseling given the risk of pregnancy in women with Turner syndrome. Importance of adequate hormone replacement therapy. And of course, the importance of transition care from pediatrics to adult care and also fertility counseling. So thank you very much. And last but not least, I would like to take this chance to promote our next Congress by CUHK, which will be happening in Kuala Lumpur, Malaysia on the 11th to 13th of September this year. And here is the QR code if you want to visit our website to register for our Congress. And we are accepting abstracts now. Thank you.